Hi, this is Patricia Kopko from the University of California, San Diego, and this is the Blood Bank Guy Essentials podcast.
Hi, everyone. This is episode 077 CE of Blood Bank Guy Essentials, the podcast covering the essentials of transfusion medicine. My name is Joe Chaffin, and I am your host. No, you are not, in fact, hearing double. If you listen to the previous episode, 076, you might be experiencing a little bit of deja vu hearing Pat's voice at the beginning. But this is, in fact, episode 077 CE, and it continues my discussion with Dr. Pat Kopko on options to fulfill the recommendations in the September 2019 FDA final guidance on bacterial risk control strategies in platelets. So we're going to talk more about that. But first, you should know that this is, in fact, a continuing education episode. The free continuing education credit is provided by transfusionnews.com. And Transfusion News is brought to you by BioRed, who has no editorial input into this podcast. The podcast offers a continuing education activity where you can earn several different types of credit, including one AMA PRA Category 1 credit, one contact hour of ASCLS PACE program credit, or one American Board of Pathology Self-Assessment Module, or SAM, for continuing certification. To receive credit for this activity, to review the accreditation information and related disclosures, please visit www.wileyhealthlearning.com/transfusion news. So as I said just a minute ago, Pat Kopko joined me for episode 076 to discuss the basics of the FDA final guidance on how we can protect our patients from receiving platelets that are contaminated with bacteria. I really urge you to listen to that episode if you haven't, because it lays the groundwork for this one. And you can find it at bbguy.org/076. So let me explain what we talked about then. No, there's too much. Let me sum up. The guidance offers multiple ways to approach this problem, ranging from things that are done in the blood center, like, for example, culturing a larger quantity sample from the platelet product or implementing pathogen reduction technology. Those are called single-step or one-step strategies, all the way to things that are done in combination by the blood center and transfusing facility, most likely anyway. And those include following a culture in the blood center, either adding an FDA-approved point of issue test within 24 hours of transfusion, which potentially could extend the platelet shelf life up to 7 days, or reculturing the product at either day 3 or day 4 of storage. Again, that's just a summary, but you need to check out the episode for more details. But before that guidance even came out, Pat and her colleague Elizabeth Allen at UC San Diego, as well as Colleen Vincent and David Reeve from the American Red Cross, published a paper in the journal Transfusion on how they implemented pathogen-reduced platelets at UCSD. It's really a fascinating paper, and you can check out a link to it on the show page for this episode at bbguy.org/077. I urge you to really take a look at this article. In fact, Pat and her colleagues have made this article open access, so even if you're not a subscriber to the journal Transfusion, you can get a copy of it at the link that you'll find on the show page. But this episode, it really consists of my continued discussion with Dr. Kopko on why she and her team made that pathogen-reduced choice and what the challenges were along the way. So I want to be clear, as I said in the last episode, I am not endorsing any one strategy over another. I can't say that more clearly. In fact, if you remember, I've had Dr. Nancy Dunbar on this podcast before in episode 060 CE, and that's bbguy.org/060. And in Nancy's environment, for example, the point of issue test works wonderfully, and she loves it. And that's great. I think the answer is different for different facilities, and my goal here is not to say that everyone should just run out and jump on the pathogen reduction train, but to show you how Pat and her team did it and why they made the decisions they made. I introduced Pat in part one of this discussion, so I won't repeat it all here, but in short, she is a Loma Linda University School of Medicine graduate for her MD and pathology residency. She did her blood bank transfusion medicine fellowship at Cedars-Sinai, and she has been a blood center chief medical officer in the past. She's now in charge of transfusion medicine at the University of California, San Diego. She's one of my favorite people, and she's really, really, really smart. So let's get right to my interview with Pat on implementing pathogen-reduced platelets. Two episodes in a row with the great Pat Kopko. I am honored. Thank you so much.
It's a pleasure to be here, Joe.
Well, it feels like it was just moments ago that we talked about, the FDA guidance. Everyone, just a little secret. It was just moments ago. But I wanted to take the opportunity to talk to you about what we had planned on talking about today, which was your very excellent article on which you are senior author. And it is currently, as of the time of our recording, in early view in the journal Transfusion. The article is called Phased Implementation of Pathogen-reduced Platelets in a Health System Facilitates Increased Manufacturing at the Blood Center. Elizabeth Allen is the primary author on that, also with Colleen Benson and David Reeve, which I believe are both from Red Cross, correct?
Yes. Elizabeth is the Associate Director of Transfusion Medicine at UCSD, and I have to give credit where credit is due. Implementing pathogen-reduced platelets was my brainchild, but she's the one who really worked on writing this up. And then Colleen Vincent and David Reeve from the Red Cross really helped us. Colleen with helping us with the implementation, and David with helping us with some of the statistics and with helping us with the description of what they did to significantly increase production.
I think that, honestly, especially in light of what has just happened with the guidance being implemented, I think that facilities would do themselves a huge favor by getting a copy of this article, which will be linked on the show page, by the way, everyone. So, Pat, let's just talk through this, because I think this is fascinating how you went to a facility that is using a high proportion of your platelets as pathogen reduced from a facility that wasn't using them at all. So I think the most basic question is, why did you decide that you needed to do this at UCSD?
Well, there's a number of reasons we chose to do this. The first, of course, is that we really believe in safety. We have really, at UCSD, we've really been working on implementing a culture of patient safety. And this is a patient safety initiative. Additionally, we had a septic transfusion reaction from platelets. And it doesn't take many of those for people to ask, well, how could we have prevented this? And of course, the answer was, well, there is this new technology that at the time the FDA had just approved that will prevent this. And then it was, well, how do we get it? And then it was, well, we have to convince our blood supplier that we will purchase it if you make it. And one of the big problems here has been the sort of chicken and egg thing, which came first.
Right.
And that's been one of the big things that we had to do, was work with our blood provider to make sure that they knew we were serious. They knew we were going to pay for it, because it is a lot of work and a lot of expense to bring this technology up in a blood center.
I definitely want to get into that. But as you were saying that, Pat, considering the audience that listens to this podcast, which is, I'm focused on people that are learning our field, I feel like I would be doing them a disservice if I didn't give you the chance, not specifically for your case. I'm not no one needs to know the specific details of your case, but just generally speaking, it's my contention that septic transfusion reactions, bacterial contamination reactions, are among the most terrifying things that can happen in our blood bank world. And I don't know if you would agree or disagree with that, but I wonder if you would just give us the thumbnail on how these things can present and what the consequences can be.
So I will give you some vague details of the patient we had. Was a liver transplant patient. And they were doing fine. It was maybe 2 days after the transplant. They needed platelets. We gave them a platelet, and they became highly symptomatic with sepsis very quickly. And fortunately for us, the transplant surgeon figured it out before we ever called her and told her, hey, the gram stain is positive.
Oh, wow. Uh-huh.
And the patient had been doing so well and then was doing so badly that she had blood cultures drawn and was giving antibiotics by the time we called her.
Wow. That's awesome.
Well, that is so awesome because I think the outcome could have been a whole lot worse had she not been so on the ball.
Again, not speaking necessarily specifically to your case. So when you say highly symptomatic, in general for people with these reactions, we're talking massive temperature increases, blood pressure changes, things like that?
Full-blown sepsis.
Yeah. Yeah.
Full-blown sepsis up to and including death.
I'm shuddering just thinking about it. I don't... Just off the top of your head, Pat, you and I obviously we graduated the same year from medical school, so we've both been around for a while. I would say I've probably seen in hospital world 3 or 4 of these, and they scared me to death every time. What's your experience been? Have you seen similar numbers or more than that?
I've probably seen a few more than that, just because of, from the blood center world way back when, and we collected so many platelets. I don't know. Let me ask you a question.
Yeah, go ahead.
Which is scarier to you? An ABO, acute hemolytic transfusion reaction, or a septic transfusion reaction from platelets?
Yeah, they're both terrifying. I have received that call on several occasions. We transfused Mr. Johnson in bed A's unit to Mr. Jones in bed B, and Mr. Jones is a group O and the unit's group A. Those are desperately scary. And as you know, patients crash really badly often with that. I'm not sure. I mean, I'll put it to you this way. The feeling of helplessness that you get with an ABO hemolytic transfusion reaction is probably a worse feeling. The horrible symptoms from a septic reaction, at least you kind of feel like there's something maybe you can do with antibiotics, et cetera. But I don't know. It's kind of a toss up to me. Both are awful. Let's just put it that way. How do you feel? Which is worse to you?
I think it's pretty much a tie.
Let's avoid them both, right?
Let's avoid them both because if you think of the scariest things that you have ever encountered in our long careers, and that's what they are. They're the septic transfusion reactions and the acute hemolytic transfusion reactions.
I would say most anything that leads you to have to make that wonderful phone call to the FDA saying that someone has died in our facility as a result of transfusion. Let's avoid all those things. That's my thought. Let's not go there.
100%.
Yeah. Okay. Well, sorry for that sidelight. So let's talk specifically about what you guys did and how you implemented pathogen reduction. I think some people out there listening to this, Pat, might say, well, okay, so you decided to do pathogen-reduced platelets. You just called your blood supplier and you started getting 100% PR-platelets, right? Isn't that how it works?
No, that's not how it works. And that's what I was talking about, the chicken and the egg thing.
Yes.
That I'm hearing all these conversations going on in transfusion medicine about, well, I can't do it because my blood supplier can't provide me 100% pathogen-reduced platelets. And I can't do it until they can. But the manufacturing for pathogen-reduced platelets is sufficiently complicated and sufficiently different that there is no way that any blood supplier can just flip the switch and provide all their platelets as pathogen reduced the day after they start the process. And it literally has become a chicken and egg thing where, well, I can't do it until I know that I have hospitals that will take it. And the hospital's saying, well, I can't take it until I can give it to everyone.
Yes. Boy, that's a perfect summary. That is a perfect summary of this. It's almost, chicken and the egg is the best way to describe it. It's like who's gonna blink first kind of scenario. So again, how did you get past that? How did you in the great mind of Pat Kopko, how did you get around that concept to say, okay, guys, let me be the voice of reason here and let's move forward?
So as you well know, I can be persuasive when I want to be persuasive.
No comment.
As you also know, I am not exactly a shrinking violet.
100% true. And that's a positive. That's one of my favorite things about you. Don't take that wrong.
And so first of all, it was not much difficulty to convince the hospital we had to do this. I went through our quality council, and in addition to doing this, we had just done the EPIC best practice alert for if you try to order blood for a patient with a hemoglobin greater than 7, it fires and says, hey, do you really need this? If you try to order 2 units of red cells at a time, it fires and says, hey, do you really need this? And says what best practice is. And guess what? We saved enough money on red cells to pay for all of this.
Look at you. Nice. Nicely done.
So I like to put it this way. We used one safety measure, which was not transfusing red cells that don't need to be transfused, because that is the safest transfusion, to pay for yet another safety measure.
Makes total sense.
So that's how we convinced the hospital. So that part was pretty easy. The second part was convincing our blood supplier, and they were open to it. They just wanted to make sure we were serious and that they weren't going to spend a lot of money on this and then have the hospital change their mind when they started getting the bills for the pathogen-reduced platelets. And we worked with them and we convinced them. And we were actually the first center in California to start taking pathogen-reduced platelets. And so it was a big deal because this was the first time it was brought up in California.
Right.
And they had to go through all the training for manufacturing. They had to bring all the equipment in. They had to get all their procedures in place and all of that to do this. And nobody's going to do this if they don't have a customer. You cannot afford to do this in the current market if you do not have a committed customer.
And I want to, Pat, explore that for just 1 second. I mean, our main focus in this discussion is to talk about the decisions that you made locally. But I think it's fair and I think it's important for people that work in hospitals to maybe have a little clearer picture of what those challenges are for a blood center to implement pathogen-reduced platelets. I have other podcasts that describe the entire PRT process, so we don't need to go through all those details. But from your perspective, why is it hard? What's the big deal? What is it that you have to do that makes this challenging?
Okay, so for all of those of you who work in a hospital, when you ask for new equipment, does the hospital just say, oh, sure, go spend hundreds of thousands of dollars. We don't care.
I'm going to say no to that one.
Exactly. And that's the same thing that would go on at a blood center, that you can't purchase all that equipment unless you know you have a customer to eventually help you pay for that equipment. And then when you have to train people to do the manufacturing, it isn't just wave a magic wand and they're trained. You have to take them out of doing their regular production jobs and put them into training. That costs money. Implementing all the SOPs costs money. Every step of it costs money. And blood centers do not have the kind of margin where they can spend the amount of money it takes to implement this without knowing they can get a return.
That's a great summary. I mean, it's absolutely true. And as I said, there are mechanics involved and logistical things from the blood center side as well that we're not going to take the time to go into in great detail. However, you do cover those in your article, Pat. So I would refer everyone to make sure you check that out, because I think it's really important, as I said, for hospitals to understand that this is not just a flip a switch and go. And I'm right there with you. Agree. So Pat, let's go back in time a little bit. So you're sitting there at UCSD. You've made this decision. You've convinced your supplier that this is something that you want to do. I'm assuming, though, based on what we've already talked about, I'm more than assuming, I know that you were hearing, okay, you're going to get a certain number or a certain proportion, whichever it was. But it was clear to you, I'm assuming at that point, that you would not be able to do 100% supply. Obviously, you've talked about that. So how did you make the decision back in late 2016, early 2017, when you were about to implement this, on who was going to get them? How did you go through that process?
So before I describe what we did, I'd like to say that there are other ways to do this.
Okay.
So just because this is the way we did it does not make it the 100% right way to do it. Others have done different things and published on different ways they've implemented and decided who gets the platelets. And you have to make a decision based on your situation and your patient population. But for us, the big deal for us was the paper by Hong that what they did was they cultured platelets at the time that they issued them.
Mm-hmm.
And they ended up having 5 septic transfusion reactions that pretty much, if they had not cultured the product, they would never have known the patient got sepsis from transfusion. Because the patients they found them in were patients with hematologic disorders, and they developed symptomatic reactions if they had low white counts, and they also developed them with a delayed onset. 4 of them were developed within 9 to 24 hours after transfusion. And so if you're doing your classic septic transfusion reaction workup, that doesn't qualify, does it? Because it's not within, 4 or 6 hours. They never would have known had they not cultured the same organism from the platelet product as they did from the patient that much later. And if you look at that population, boy, we have a huge population like that at UCSD. We have a bone marrow transplant ward. We have an outpatient cancer center. We give a lot of platelets to patients who are neutropenic and outpatient. And if you look at the Hong paper, the patients who had the septic transfusion reactions, the patients who died from the septic transfusion reactions look a whole lot like where a lot of our platelets go. And so based on that, we decided, well, let's go ahead and start giving these to our patients who are outpatient, and if they have a reaction, do not have immediate access to advanced levels of care. Mm-hmm. And B, patients who are often very neutropenic. And that's how we decided how to start. And we started using them in our cancer center for our outpatients, because one of the things that really impressed me from that prior reaction we talked about was how quickly the patient got treated. And I truly believe that had there been a significant delay in treatment, the outcome may not have been as good as it was, because the patient actually ended up doing fine.
I'm so glad.
But what if there had been a several-hour delay? And our cancer center is truly an outpatient environment. We can't call a code. We have to call EMS. And what if they become symptomatic 9 hours later when they're at home?
You'd either never know or you'd know too late, right?
Yeah.
Neither is good. Okay, so those were your first priority, those outpatient patients in your outpatient cancer center. And I believe you called that phase 1, right?
Yes.
So did you, before all this started, had you already defined what your phases were going to be, Pat, or did you figure those out as you went along?
We knew what we were going to do before this started, based on our previous experience and based on knowing what our population is. We thought that the next group of patients to get these products should be the inpatients on the bone marrow transplant unit.
That makes sense.
because they also are neutropenic. And if you think about it, if you look back at that Hong paper, it kind of makes sense that if you have lower levels of bacteria in your platelet unit, if you transfuse it to somebody who is fully immunocompetent, and has a normal white cell count, they may never get sick.
Mm-hmm.
But if you give it to somebody who just had a bone marrow transplant who has no white cells, it could be a very different outcome.
Absolutely. So phase 1, outpatient cancer center. Phase 2, inpatient bone marrow transplant ward. What was phase 3 for you?
Phase 3 was the whole hospital.
Okay. That makes sense. Did you have numeric goals? Did you have an idea of what you wanted to do, or a proportion of pathogen-reduced platelets, for example, that you wanted to get to?
We wanted to get to over 90% pathogen-reduced platelets in 6 months. And that was a lofty goal that, since you've seen the paper, we did not get there.
But it was a valiant effort, for goodness sake.
It was a valiant effort.
Well, but I actually think that's important for us to discuss. So once you got to your phase 3 and you were releasing, it's pretty much all comers. You, as you said, you didn't get to that 90% within 6 months. I wonder if you'd take us through what you did get to and what you saw as the why you weren't able to get farther. Okay,
so phase 3 started 3 months after we began. So we began this whole journey in February of 2017. And we were at 53% of all platelets several months in. And we really were not happy with that. We just thought we could do better. So then we worked with the American Red Cross and said, hey, look, we're serious. we want 100% of our platelets as pathogen reduced. Not 53%, we want 100%. But if you can get us to 90, we'll be much happier. Because we want to go this direction. And so we worked with them, and they decided that they needed to make some changes in their manufacturing processes. And what those changes were is, it turns out that there's these things called guard bands, is what they call them. And the FDA has not approved the pathogen reduction process that is approved for, you can just put any platelet unit into it. It has to meet certain, what they call guard bands, which the volume and the number of platelets in the product have to fall within specific ranges. That means not all platelets can go into the pathogen reduction process. Additionally, there's no triple kit. Yeah. So think about that.
Yeah. As a blood center, that seems a significant issue, because we try to, as you know, we try to make as many of our platelet collections as we can triples. Yes. If the donor qualifies.
Yes. And as you know, larger donors with large platelet counts make good triple donors. And so it's just, for a number of reasons, we try to make as many of our collections as possible triples. So the Red Cross decided that to get to where they wanted to be and where we wanted to be, they needed to make some changes in their manufacturing processes. And what they did was they optimized the settings of their platelet collection devices to ensure that they were meeting guard bands as much as possible. And then the other thing they did was they had previously not been treating triples at all, because there is no triple kit. Although there is no triple kit, the FDA has gone on record as saying, yes, but you can split it into a triple and pathogen reduce each of them.
Oh, say that again.
You can split the triple into an actual triple.
Oh, I see.
And pathogen reduce each one.
Yes.
Gotcha. And so there is no triple kit per se, but the FDA never said you can't treat triples.
I see. Big difference.
Big difference. It may sound semantic, but it's not. There were blood centers who thought that meant you couldn't treat triples. And so they worked hard on identifying eligible double and triple platelet products that they could split and pathogen reduce. And so they made, in fact, if you look at the graphs, you'll see that there's this period of time where we had sort of increased and then we sort of decrease. The percent decrease is from when they were optimizing the manufacturing, because they had to do some retraining. They had to change some things around. But then after they optimized their pathogen reduction process, we were up at over 90% very quickly. And we've pretty much stayed there.
So roughly how long did that take until you got over towards your 90% goal?
At about 15 months in, we were over 90%. But remember, we were a really early adopter. I don't think it will take others 15 months.
Why? Why do you think it'll be better in the future?
Well, that's the other thing that you can see in the graphs on the paper, is that at first, when they started doing pathogen-reduced platelets, they only had one hospital in all of California who would take the product.
The definition of a limited market.
Yeah.
Right?
So, and you can see we did the statistics here of looking at, there's a correlation between the number of hospitals that could accept the products and their ability to provide us with pathogen-reduced platelets. And the more hospitals that could accept the products and would accept the products, the more they were able to provide us, because then they didn't have to worry about, well, literally, if we make one extra platelet that's pathogen reduced, we have no hospital to send it to. We have no hospital that can even put it into their computer system.
You brought up something that I think is important. And just from the practical perspective, are there things that a hospital transfusion service would need to do, for example, with computer systems in order to be able to use these products?
Of course. As with any product, you can't take it into your computer system unless you've built the appropriate product codes into your system. And so one of the things I would advise pretty much every transfusion service is to go ahead and build the product codes for pathogen reduction. Do it now. Because what if you need a platelet and the only platelet your blood provider can send to you is pathogen reduced? Mm-hmm. What if you need an HLA matched platelet and the only one they have is pathogen reduced?
Yeah.
Build the codes now. The other really interesting thing we had to deal with was all of the issues around irradiation and CMV negative.
Set the stage for us on that, Pat. Why is irradiation and CMV an issue or a consideration with pathogen-reduced platelets?
It turns out that if you think about it, we're pathogen reducing these products to get rid of the bacteria, but they get rid of a whole lot of other things too. If you're worried about things like, malaria, babesia, HIV, HCV, CMV. So if you have a pathogen-reduced platelet, it is equivalent to a CMV seronegative platelet. So if you're planning on ordering CMV seronegative, you don't have to do that anymore. But how is your computer going to recognize that product as CMV seronegative? And it also turns out that the damage that the pathogen reduction process does to DNA and RNA is actually superior to the damage an irradiator does to DNA and RNA. And so it can be used in place of irradiation. But how do you get your computer to recognize that the product is irradiated? So we thought about it a while. We were going to add a PR code, and we figured out our computer system wouldn't let us do that and have it equivalent to irradiated or equivalent to CMV negative. So we tricked our computer into thinking they were the same thing. We changed our codes to, we used to have IRR for irradiated. We now have IRR PR. And we used to have CMV neg, and now we have CMV PR. And what we did was we reprogrammed the computer to recognize them as equivalent. So when a product comes in and it's irradiated, we just put an IRR PR code on it. If it's pathogen-reduced, we put an IRR PR code on it. We also put a CMV PR code on it. So then the computer recognizes it as pathogen-reduced or irradiated or equivalent. And that's a big deal because without it, you can't release the product.
Right. If it needs to be irradiated and your computer doesn't recognize that product as equal to irradiated, then you're kind of hosed.
And a whole lot of the platelets we issue need to be irradiated. And that's the other thing we did. We were concerned that the nurses would be returning them because they weren't irradiated. And so what we did is we developed this little sticker that we put on the tag. And it says, this product is pathogen reduced, which is equivalent to irradiated.
Nice. Nice.
And we've not had a single nurse call and say, hey, you didn't irradiate my platelet.
That actually brings me to what I wanted to make sure that I asked you. And so you mentioned you did that for your nurses. How did you go about, I don't want to use the phrase selling it to your medical staff, but it's kind of in a way. Did you have discussions with your medical staff prior to implementing this? I assume you did. How did those discussions go? Were there any objections raised?
So I presented this at our quality council, which has medical staff from basically just about every discipline. And every one of them was in favor of doing this because it was such a patient safety thing. But then the next thing we did was, if you think about who are your thought leaders on what's okay and what's not okay clinically for transfusion, and they're your hematology oncology doctors. Mm-hmm. And so we met with our head of bone marrow transplant, and he said, yeah, we need to do this. Yes, this is okay. Yes, it's okay that we don't irradiate. Once your head of bone marrow transplant says what they're doing is okay, your other medical staff are going to believe that. But in addition, we sent out a communication to all medical staff saying we were making this change, and these are the changes you would see, and some pictures with it of that the bags look a little different. And we got no complaints. Not one.
I'm not surprised. And my guess is, I mean, again, if your hospital is anything like hospitals I've worked in, my guess is at some point you had people coming up to you saying, hey, when did you start this? This is kind of cool. Did you have conversations like that?
Yes, occasionally there'd be people who ask, how long have we been doing this?
Yeah. So as we close this out, Pat, there's a couple things that I think are really important for us to discuss. And I want to circle back around to what we talked about at the beginning in terms of your phased implementation. Because I think, and you raised this in the discussion portion of your paper, I think there are some who might argue that there's an ethical issue, a justice-related issue to supplying what can be perceived as a safer product to some patients than to others. And your answer to this might be different now that the final guidance has come out and there are requirements for basically every platelet that we transfuse. But how did you work through that ethical argument in your mind and the discussions that you had with others?
Well, for us, because we use so many platelets and so many of them go to outpatients who have low white counts. That Hong paper was just instrumental for us in saying, some centers have done first in, first out and just mixed them with everything else and taken care of the justice issue by saying you have an equal chance of getting the pathogen-reduced platelet as everyone else. And had we not had the unique circumstance of our cancer center and the infusion center there is physically separated from our hospital, I may have done that. But that Hong paper made such an impression on me that the patients who are most at risk were the outpatients with low white counts. And so we decided to go for where we knew we as a medical center had a risk and give them to who we knew from this documentation in that paper, they were at the highest risk. Now, had that infusion center been in the hospital, I might not have made the same decision. And I think it's really important when you make these decisions, you have to look at what you have in your organization and what best fits your organization and your patient population.
I could not agree more with that statement. You're absolutely right. And that actually brings me to the next question, which I'm going to ask you for your interpretation of this or your feeling on this, with the acknowledgement that that your answer may not be the right answer for everyone. And it's a practical question. And again, you raised this in the discussion section. Say you have a pathogen-reduced platelet that it's about to expire, and you have another product that is potentially a better ABO group match for the patient. How do you make the decision on which product to choose in that scenario, and what are the pros and cons of each?
So one of the things about our pathogen-reduced platelets is they're all in PAS, so we don't have as much of the ABO issues.
Help everyone understand that, Pat. Why is that less of an issue?
Because 65% of the plasma is replaced with platelet additive solution, which means you have 65% less plasma in these products.
Mm-hmm, mm-hmm.
And so for us, that's probably not as big an issue, but every patient is unique. And if I was asked that question, I'd have to look at it and balance, okay, which do I think is a better product for this patient? And fortunately, and you brought something up, if I have one that's about to expire, honestly, that doesn't happen to us that much. And the reason is, this is the other thing I really wanted to talk about. We work with our blood provider. And we have two hospitals. We have one that is next to downtown, and that's where our trauma center and our burn unit is. And so you can imagine we have to have a lot of platelets on the shelf for the trauma center.
Of course.
But our cancer center and our bone marrow transplant unit is 13 miles from there. Now, you can imagine we have to have a really lot of platelets on the shelf for them. And so
of course,
we worked with our blood provider that when the platelets get to day 4, they pick them up and take them to the other hospital for us.
Oh, interesting. Mm-hmm.
Yes. And so that's really helped us with our platelet supply. And so we don't end up in that situation that much because we use so many platelets.
Sure.
But if you think about other hospitals, that's not necessary. And we're urban. So if you think about other hospitals, I think Nancy Dunbar's been on your podcast. And
she has.
She talks, they do it completely differently at Dartmouth, but they're a completely different organization than we are. They're rural. They are a long way from getting restocked. It snows there.
Wait, what? Snow?
It snows there.
We're Californians now, Pat. We don't talk about that.
And so, if you look at what they've done And extending platelets to 6 and 7 days, that makes a whole lot of sense for them. It doesn't make as much sense for us as an urban center that really uses a lot of platelets and does not outdate many at all. Our biggest problem is, hey, we need more.
Right.
Hey, we're down to 8. We're panicking.
Yes, I hear you. And so everyone, Pat mentioned the great Dr. Nancy Dunbar and her protocol at Dartmouth. You can hear about that, just sidebar for a second, Pat, on bbguy.org/060. That's episode 60 of this podcast. And the last part of it, Nancy talks about the choices that she and Dartmouth made for platelets that are, as you said, different than the decisions that you've made. And I think that's really important as we close this down, Pat, for people to understand. And we've emphasized it. We emphasized it in the previous episode, talking about the guidance, and we're emphasizing it again now. And we've already done so. The answers are not the same. There's no one size fits all, right? I mean, people have to figure this out for themselves. Yes.
And I let me just tell your listeners, if you haven't heard that podcast, it's well worth the time. It's a really good podcast. And she discusses why they've made the decisions they've made, which are completely different decisions than what we've made at the University of California, San Diego, but they are still very valid and well thought out decisions.
I would expect no less from Nancy, right? She's
right.
Yeah. Well, anyway, so Pat, as we close this out, what are the things that you want to leave us with? I guess as you leave us, I wonder if you would also discuss how does the guidance being finalized impact what you're doing and what you're planning to do, as you said. And in fact, you mentioned this in the early view version of your paper. When you wrote it, the guidance obviously wasn't out yet. With what you know now, does that change anything for you?
Well, it doesn't change a lot. We still want 100% pathogen-reduced platelets because, honestly, between you and me, I think we're eventually going to get there.
Mm-hmm.
I think
between you and me and the 4 or 5 other people that listen to this podcast, right?
Between you and me and your occasional listener, I think that's where we're going, but we can't get there tomorrow. So I recognize that on occasion, we're going to get a platelet that is not pathogen reduced. And in those circumstances, I am okay with anything in this guidance. However, as you know, I've spent a long time at a blood center, and now I've spent a long time in a transfusion service. I firmly believe manufacturing, as much as possible, should be done by the donor center. So therefore, I am going to let our donor center know that we would really like them to do the manufacturing.
And we'll just leave it there. As I said, we're not here to recommend one particular thing or the other, but I hear you loud and clear. I think that's going to be a fairly common answer. But as you said, for others, that they might come to a completely different conclusion.
Right.
And that's fine.
But you know what? That also has to do with where you're at. Because in California, we have to use, for all of the step 2 ways that you can extend the life of your platelet or even get it to 5 days with an early culture, you have to use licensed clinical laboratory scientists.
It's a big thing. Big thing. Yep.
And for California, that's a big thing. We don't have an excess of those highly trained, highly intelligent people. And so for us, that's part of the cost equation too, is the labor and even being able to find those people and hire those people. And that may be a different calculation in different parts of the country. Can I add one thing?
You can.
Something everyone needs to know about the pathogen-reduced products. The bags are bigger. Now, you think, so what? Well, if your platelet incubator is crowded already, they're not going to fit and you need to buy a second one. Just something to think about.
That is a very practical tip that is important for people to know.
So at one of our hospitals, we have 2 very large platelet incubators, so it's not a problem. The other hospital, the one that doesn't do the bone marrow transplantation, has a single platelet incubator, and we're going to have to buy another one.
Well, Pat, I can't thank you enough for doing this. Not just for talking about this with me, but for the paper that you and your group have put out, which, as I said, everyone, you can find that paper on the show page for this episode. There's a ton of great information in there that I think people, especially in light of the new guidance being finalized, can use to, again, guide them in a way that may make sense for them to go the way you've gone, or may make sense for them to do something different. But I think it's a really valuable contribution to everyone, as is your time with me, Pat. I appreciate both so much.
Thank you, Joe. It's been a pleasure to be on the podcast.
Hi, it's Joe with just a couple of quick closing thoughts. I hope that this conversation and the one that preceded this one in episode 076 stimulated some thoughts for you regarding how, if you practice in the United States, you're going to approach the recommendations in the FDA guidance from September 2019. As I have mentioned, I think multiple times, I think each facility should read the guidance, start a conversation internally with your blood supplier, and start to form a plan. Your plan may be different from someone else's, and certainly may be different from what Pat and her team decided, and that's okay. There are options, and you really need to explore them. I do want to mention again, this is a continuing education activity. So if you are a physician or a laboratorian, don't forget to visit wileyhealthlearning.com/transfusion news to get your hour of totally free continuing education credit. My thanks for that, as always, to Transfusion News, to BioRad, who brings you Transfusion News, and to Wiley Health Learning. I want to thank again Transfusion News Assistant Editor, Dr. Daniela Hermelin from St. Louis University. Daniela helped me very much with the continuing education materials for this episode. So thank you so much, Daniela. I've mentioned in the past that I have a terrific interview coming with one of the inventors of pathogen reduction technology, Dr. Ray Goodrich. I felt like we needed to address the FDA guidance right away, though, so that episode will be coming soon. In addition, I'm excited for you to hear from Dr. Mindy Goldman from Canadian Blood Services about choices she and CBS have made in Canada regarding donor and patient safety. I also have coming soon a roundtable discussion with some laboratory science leaders in transfusion medicine, including one of my heroes, Sue Johnson from Versity, Wisconsin. In that roundtable, we talk about how lab science students and practitioners should understand why blood banking is a fantastic career choice. I can't wait for you to hear that one, and it will be out before the end of 2019. But until that day, my friends, as always, I hope that you smile and have fun, and above all, never, ever stop learning. Thank you so much for listening. I'll catch you next time on the Blood Bank Guy Essentials podcast.